Hi, I'm Jim Brett, President and CEO of the New England Council. Thanks for tuning in to this month's episode of Inside the Corner Office, where we catch up with the leaders of some of our region's most well-respected businesses and organizations to learn more about their career paths and about the institutions they lead. This month, I sat down with Tess Kuenning, President and CEO of the Bi-State Primary Care Association, as Tess marks an incredible 30 years at the helm of the organization. We talked about her early career as a nurse, including 4 years spent working in Nepal, her transition into public health, and the tremendous growth Bi-State has experienced under her leadership. We also discussed the critical challenges facing community health centers in New England today, from workforce shortages to recent federal budget decisions that threaten essential services like Medicaid and SNAP. Tess offered her insight on how these changes will impact some of the most vulnerable populations in our region, and how community health centers are adapting to meet evolving community needs, including mental health and rural healthcare access. As always, I thank you for tuning in, and I hope you enjoy this episode. Tess, thanks very much for taking the time to join me today. It's such a critical time for primary care and for the community health centers. And one thing that I've learned in hosting this podcast is that we have some really incredible leaders here in New England who bring very unique experiences to their roles, and you are no exception. So we'd like to start off by just talking a little bit about your background.
Sure. I'd like to start first by thanking the New England Council for this podcast, and also congratulations on your 100 years. That's a pretty remarkable milestone for a business community that has come together over New England. So first, congratulations to you as well.
Mm-hmm.
So I started, I'm a nurse. I've always been drawn to caring for people. It's from a very young age. I think it's just who I am and part of my DNA. And I take a lot of pride and joy in caring for people. And there was one quote that I learned really early back, which is, there's nothing so unequal as the equal treatment of unequal. And it's sort of the difference between equality, meaning you treat everyone the same, or equity, where you provide everyone with what they need to succeed. And it involves different approaches and different resources. And I think that's just been part of who I am.
Mm-hmm. So what inspired you, though, to pursue that career in nursing?
Oh, I have to say that there was a family friend that was a nurse, Joe Stats, and I was so enamored by her at a very young age. And they used to, at that time, when I was growing up, make house calls. The doctor would come, the nurse would come to the house, and I always admired her. So she was really instrumental in many ways to kind of the yearning that I had to do caring and put it into a profession.
Yeah. I was intrigued to learn, I thought I knew everything about you, that early in your nursing career, you spent 4 years in Nepal working in child maternal health. I'd love to learn more about that experience and how it helped shape your career.
Yeah, thank you. Yeah, it was a bit ago, a little over 40 years. So I was working in cardiac critical care ICU for about 5 years, and I just wanted to shift to community health. I thought it sort of fit me a little bit better. I always had a bit of a wanderlust. I was a foreign exchange student in high school. I went to Denmark, and then I studied in Salzburg, Austria for college, and also in Rome. So I sort of had a widened aperture early in my years, and I was always really intrigued by Nepal. So I don't know whether or not you remember, but back when I was young, there was a door-to-door salesman with an Encyclopedia Britannica books,
Mhm.
and you'd buy A and B, and then you'd buy C and D, and it was sort of our library at home. And then we also got the National Geographic magazines, and I saw the Sherpas in the mountains, and I thought, oh, someday I really want to go there. So there was a huge sort of dramatic change from, high tech to very low tech. I went to Kathmandu. I lived right outside of Kathmandu in a Tibetan community. There was refugees from Tibet. But I lived with a Hindu Brahmin high caste family. No one spoke English. We had one electric bulb in the house, mud floors, mud hearth for kitchen, a cow, a chicken, and a lot of gardens for food. We had three clinics. One was near Kathmandu, and then one was a 2-day walk north into the mountains. And then one was way out in the far west, which you'd take a plane to the lower, what's called Terai in Nepal, and then walk for 4 days to get to the clinic. That was actually called a cultural sanctuary, and they weren't allowing anybody into that sanctuary for any sort of services, healthcare or agricultural services, unless you knew the culture and knew the language. So in that particular clinic, we started a literacy program for young girls. And when they graduated, they got a goat. And that was a way to bring kind of economic development or economic opportunity for young women who really had no other way of being able to support themselves or their families. So the clinic didn't have a maternal child health program. So I integrated sort of the Western part of a maternal child health program and worked with traditional birth attendants, which are usually older women in the community who help women through their pregnancies. And then also with the Jonkries, which are the faith healers. And we worked together to sort of build a cultural program that looked at perinatal practices for live, healthy birth outcomes. And it was very successful. We really increased the number of women that were coming to the clinic. Most of the women at this time birthed in a barn for cultural and religious reasons. So many times I would be there at the birth, right in the barn with them, to help them through the birth itself, and then do all of the sort of perinatal, prenatal, and postnatal support. We did a train the trainer, so that when I left, there would be people that could support the practice. So we had these birth training kits that had a stethoscope and gauze and a razor, a clean razor, and to cut the umbilical cord, and soap. And then in Nepal, I also worked for the Sisters of Charity, Mother Teresa's order. There was a leprosy clinic there, and it was folks were just incredibly destitute. There were people that society sort of shunned: leprosy, end-stage tuberculosis, mental health, physical disabilities, chronic illnesses, tardive dyskinesia, like people that had tics and movements and outbursts. So that was it was a great part of it was outside of the clinic, but a great part of my time in Nepal. And then most importantly, I met my husband of 40 years in Nepal. He was working in Kathmandu as well.
Oh my God, great story. Uh,
Yeah, thanks.
when you returned to the U.S., you transitioned to a public health role at HHS. What prompted that shift away from bedside nursing to public health?
Yeah, it's a great question. I really love the intensity of the ICU, and I also love the remarkable work that I did in Nepal. I did my master's in public health and community health with a focus on maternal child health. And so I was drawn a little bit more to a larger population health, kind of a broader community engagement and interventions, things that could be achieved by large scale and scaling up programs. So when I came back, I worked for the U.S. Surgeon General in the Boston regional office. And that's what opened me up to community health centers, who I'm now very privileged to work for.
I understand that you are celebrating a very significant birthday at Bi-State Primary Care this year, 30 years leading the organization. And I know firsthand that it has undergone incredible growth needless to say, under your leadership. But can you share more about how the organization has evolved in the last 3 decades and what the current footprint looks like?
Sure. Yeah, so when I came in 1995 here, 30 years ago, Bi-State is an organization that was founded in '86. So there was a group of committed folks who were really interested in enhancing access to care. And at the time, there was only one community health center in Vermont and one in New Hampshire. It was Northern Counties in the Northeast Kingdom and then Lamprey Healthcare in New Hampshire. And so they actually came together with programs like WIC and family planning um, uh, and sort of single unit organizations. And then it was growing from serving about 10,000 people at the time that I came to now we have 28 community health centers and affiliated organizations serving about 330,000 people. So there has been a lot of growth in the access. The sorts of things that we do at Bi-State are to do work for the community health centers that help them with their financial performance, with their clinical performance, with operational performance. We do data analysis for them. We have a workforce development program. We do a lot of policy work, both at the state and the federal level. And then we do a lot of collaborative efforts to try to make sure that in the community where the community health centers are, they're maximizing their relationships vertically with the hospitals and specialty practices and mental health and home health, and then also network uh, with each of the health centers. So there, we provide a space for the community health centers to come together. We bring the CEOs together. We were bringing them together more recently, about once a month, where we provide support to them, give them the information about what's happening at the State House, because we have a person in the organization that does the front-facing work in both Vermont and New Hampshire. But I would say the cornerstone of the work that we do is our national and state government relations work, as well as workforce. I think those are two pillars that the health centers really rely on.
As we talk today, needless to say, community health centers, not just those in your organization, but throughout New England, are facing a variety of challenges. But one of them is that workforce shortage and primary care providers. Can you talk a little more about what you're seeing and how the community health centers are working to meet the needs of the communities that serve while grappling with the shortage?
Yeah, thank you. Yeah, so the Workforce Recruitment Center that we have does like national campaigns to recruit healthcare providers both in New Hampshire and Vermont, and helping to support when we do our work with government relations, sort of the policy levers in retaining the healthcare providers as well. We help support things like career ladders and apprenticeships and community-based residencies. We have a program that uh, is with the Harvard, the dental school. And so that's a program that brings dentists to practice here in Vermont, and actually just in New Hampshire for that one. But, I mean, I think the workforce challenge is we think primary care, and I believe this, that primary care is the backbone of our healthcare system, yet the primary care providers haven't seen the kind of corresponding investments. And so I'm sure you know Chris Kohler at the Milbank Memorial Fund. And this February, they put out a report that looked at the national spending on primary care. And in 2022, primary care spending was under 5% of the total healthcare spend. And then that was also true for Medicare. 3.4% of the total Medicare spend is on primary care, and Medicaid is 4.3. So there's this reimbursement or ability to be able to bring down significant dollars for primary care for investments. So the pressure on primary care is really real. It's the one thing that the health centers say keep them up at night, one of the main challenges that they have. And it's not just physicians and nurse practitioners and dentists. It's sort of, you think about the entire sort of workforce, if you will, and it's the front desk, and it's the medical assistants and the dental assistants. It's the the LPNs and the RNs as well. And so there's a lot of pressure on primary care to be able to pay higher. And we've never been able to pay as high as the specialty fields. And so sometimes when students are in school, they'll gravitate to the higher paying jobs. And sometimes it's difficult to get a number of primary care providers. I think the HHS, this is federal HHS, said in the next 15 years, we're going to need something like 68,000 physicians, primary care physicians, 9,000 dentists, and then about 100,000, I think, of mental health providers. So finding a way to reduce the burnout, to bring them to the community health centers and uh, make investments in their practice. Some of them like teaching, so some of them have relationships with like UVM or with Dartmouth to be teaching and having some of the students come. So that's excuse me, some of the excuse me, difficulties we have. We did a request, a survey essentially of the community health centers in Vermont and New Hampshire in 2024, and the vacancies topped 300. And this is just in 28 practices. This is not the Dartmouth system or the UVM system or the Elliott system. This is just in our community health centers. So it's a constant need of the community health centers to sort of bring in resources. There are some federal resources that they really rely on. So things like the National Health Service Corps. So it's a program where you either are a scholar and they'll take you through medical school, but then you owe time to be serving in a medically underserved area. And Nurse Corps, teaching health centers. So we have a teaching health center graduate medical education, two rural organizations that we've just started, one up in Berlin in the North Country, and then one in Vermont, to be able to bring in family practice residents to be able to serve in community health centers. And I think there's about, just in New England, I think there's about 1,400 people, community health center providers, just in the community health centers, that utilize those scholarships and the loan repayments. So it's a really important investment. And to the point that I was making earlier, the investment in primary care, both from the federal government and the state, is not there. And one of the things that I mentioned to you just before we started was, thinking about the business community and those that are part of the New England Council, and really trying to demonstrate the value of primary care, the value of having a relationship with a community health center, because it's often small businesses use community health centers for their employees and for themselves. And so we want to be able to demonstrate the value back to the community, and part of that work is to get federal government to make further investments in primary care and in workforce, but also to just sort of think about the, kind of the economic driver that community health centers are in our communities and in New England.
The community health centers has a reputation of taking care of the most vulnerable members of our community, and some of the community health centers are in more urban areas, while others serve regions and more remote rural communities. What are some of the unique challenges these centers face in the urban versus the rural settings?
Yeah, thank you. So one of the things I didn't mention, so I'll sort of back up on what a community health center is, providing this multidisciplinary comprehensive care. So it's not just a medical visit, it's also a visit in terms of mental health and behavioral health, medication-assisted treatment, substance use disorder, vision, dental, oral health. So it's this very wide breadth of support that they provide to the communities. And a community health center, by its nature, has to be in an underserved, a federally designated shortage area. So since they're located in medically underserved designated shortage areas, regardless if you're urban or rural, there's already a dearth of healthcare services or facilities or providers. So some of the unique challenges, it's interesting, some sort of parallel in both the urban and rural. There's about a 60-40 split in nationally in terms of the community health centers. 60% are in urban areas and 40% in in rural. And some of the things with rural would be, of course, the distance, between the patient and the provider. And there aren't a lot of, in New England, there aren't transportation systems, especially in our rural communities. And then, of course, we have our mountains, kind of the topography. That is a challenge. It's sort of how the bird flies. You're not going to get there in 20 minutes. It's going to take you, you've got to go over through the notch. There's lots of storms and weather issues for some of the patients. Many of them do not have cars, can't afford cars. Housing options are more limited in the rural areas. And then wages and reimbursement opportunities really lag behind the urban areas. And so they struggle a lot to stay current with the labor market and sort of those wage limitations. There's been a lot of improvement in the connectivity, which sort of at some point, I'll maybe mention a little bit more about all the telehealth that we're doing, but the internet connectivity in the rural still lags behind things that we get in the more urban areas. And then network adequacy, whether or not there's enough providers in the rural areas, and sort of, as I mentioned, sort of that distance. There's also this concept of sort of a food desert, where food access is more challenging because they have limited proximity to be able to go to a grocery store. And we have some work that we're doing at Bi-State in food security. So I can speak a little bit more about that. We have one community health center up in Vermont that actually has a not-for-profit grocery store that's right in the building of the community health center. So trying to find creative ways for that as well. And then, of course, the aging community. We're one of the states, I think maybe just behind Maine in terms of how old our community, the people are in Vermont and New Hampshire. So that's also another sort of issue with the rural areas. But then when you go to the urban areas, sometimes some of those same challenges exist. So transportation, you have to take maybe 2 or 3 buses to be able to get to a community health center. And if people are limited by time, if they're working in jobs where, it's just 9 to 5, and so it gives you less time to be able to get to the practice. Housing, of course, I mean, that is just prolific across New England in terms of the housing shortages, both urban and rural. And so the insecurity of not having housing, I think, is really difficult. And you have congestion in the, I think there is some studies that say that there's a little bit more challenge with respiratory illnesses if you're in sort of a large congested area. And then many of the urban community health centers, this happens in Boston and all across our states, but our urban health centers have a disproportionate number of people who have language barriers. So they're drawn to work where other immigrants are working in community. And so I know the Manchester Community Health Center here in New Hampshire has 65 languages spoken. And they have probably 10 staff that speak, their predominant languages, the Spanish and Portuguese and Nepali and Arabic. But then they also use like a telehealth. So somebody else comes in the room with them that allows the visit to happen in the person's language of origin. So those are a couple things that I think about when I think about sort of the barriers to care and the differences between rural and urban.
We've seen a heightened focus on mental health in recent years and an increased demand for services. Can you speak more about the role the community health centers in the region are playing to meet those demands? I would think one issue that, one barrier is just finding enough mental health,
Mm,
physicians. I would think that
yeah.
would be a huge challenge.
It is, and we have an experience here at Bi-State where we began a program probably 3 years ago to recruit, just like we're recruiting MDs and DOs
Oh,
and nurse practitioners, to recruit mental health specialists. And we found it was so difficult because there were a lot of difficulties with the credentialing and the number of hours that social workers needed to have in clinical experience, and none of that is reimbursed. But it was really difficult to recruit the mental health providers. We've seen an increase in telehealth with the community health centers and behavioral health. Behavioral health is increasingly the most common condition treated at a community health center, which that statement alone is just sort of worth a pause. And nationally, community health centers, it's part of the scope of what they are required to do, mental and behavioral health. And so the about not quite 100%, but almost of community health centers offer mental and behavioral health services, but are only able to reach about less than 30% of what the demand is. And to your point, which is finding providers
mhm.
are that are skilled in being able to help with mental health, and it just makes the conversation that we just had earlier about
Well,
workforce investment, right? And
yeah.
so being
Mhm.
able to bring more pipeline of mental health providers into the community. The health centers, all of our health centers in Vermont and New Hampshire offer medication-assisted treatment for patients with substance use disorder. So that is new, and part of the Medicaid expansion that happened, with it coming into law in 2010 and then being actualized in 2012. Part of those essential benefits were mental and behavioral health and substance use disorder benefits. So for example, in New Hampshire here, our traditional Medicaid didn't have a substance use disorder benefit. So when the Medicaid expansion came and it was in that suite of benefits, then the state made a decision to have Medicaid, the substance use disorder benefit for everyone. So we've seen a real growth in that. And part of it, I think, is COVID, where it was a difficult time. There's a lot of data that shows that, kids in school had a lot of difficulties. Parents had a lot of difficulties trying to manage, work from home and kids homework. So we are seeing just an increase in mental health visits. The one thing that the health centers are doing is that they are doing one of two things. They're either bringing the mental health providers into the community health centers so that when a person um, comes in and is diagnosed with something that they need a mental health counselor for, they give a warm handoff. So that person has a lot of availability in their schedule and they do a warm handoff. The other reverse of that is in the mental health centers, the community health centers send one of their primary care providers. So in a mental health center where it's more persistent mental illness, if there's something that they see their patient needs in terms of primary care, then the primary care provider is right there as well. And then, as I mentioned earlier, just the telehealth for mental and behavioral health. It offers a really great sense of privacy, and you don't have to leave work as long as you can find some place to be able to take the call, and kind of reduces the burden and the stigma. So a lot of people don't like to go into a waiting room where they know they're being treated for mental health. So that has been a great help. We do have from the COVID era, we have an ability of the providers to do mental health, but we do have also that is ending in September 30th. So we're going to try to get the ability to be able to do telehealth visits virtually and continue that nationally, which is really important. Maybe about 35% of the visits in New Hampshire and Vermont community health centers are are done through the virtual telehealth, and only about 3 or 4% of the primary care is done through telehealth. So it's a really great tool for the practitioners to have to be able to reach more people.
Is there any problem with Wi-Fi in those rural areas that people are unable to access into telehealth?
Yeah, yeah. Wi-Fi is one of the issues. The other issue is just digital illiteracy, like people who don't have a smartphone or don't have a computer and don't know how to run one. And so, how do you teach someone to be able to use the kind of technology that is available, but they may not have the resources to be able to afford one. They may not have a smartphone to be able to use it. So I think the connectivity issue is a problem. There has been, of course, through the Biden administration, a lot of
Right,
investment made
right.
in that space, and so we see it
Mhm.
less, but it definitely is in some of the rural pockets. It definitely is still a problem.
You know, as we speak today, Congress has passed, and the president signed into the massive budget reconciliation bill that I know has delivered some devastating blows to the community health centers. First and foremost, devastating cuts to the Medicaid funding. Can you speak how those cuts will impact our region, and but more importantly, how it's going to impact the community health centers?
Yeah, it's a great question. I think we know some things and we don't know others. For the working poor, it's incredible deleterious bill. It's just a tsunami of changes, not only in the Medicaid space, but also in the marketplace space as well. And then some of the other programs that are really important to people who have low income, such as the SNAP programs, LIHEAP, the heating and fuel assistance. I think there's going to be this just cascading effect where you're taking almost $1 trillion out of the federal spending for Medicaid. So just think about that,
Mhm.
$1 trillion over a period of time of less spending for Medicaid. And this is happening through um, instituting a work requirement. And we've had experience here in New Hampshire with a work requirement a number of years ago. And after 2 months, the state of New Hampshire had to stop because there was like tens of thousands of people that were coming off of Medicaid. And so they realized that um, the way that they instituted the work requirement wasn't going to work. So this is now a federal program. All states have to follow it. I think the Medicaid lack of spending is going to really destabilize the Medicaid program. There is this devolution of intent by the federal government in this administration to put more onus on state spending. And it comes at a time when states are having difficulty getting their own budgets through um, and without going into deficit. And it comes at a time when the need is so high. So it's just this sort of clash of a policy that's coming down to states who aren't ready either with the human capital or with the resources to be able to take on more with Medicaid. So there's about 70 million people that are on Medicaid right now, and in the marketplace plans and in the Medicaid expansion, so those were things that came out of the ACA, there's about 45 million people. So the numbers that you see are that 17 million people will be uninsured, but I think people are thinking about it just in too parochially, because if you think about taking that kind of revenue away from a practice, be it a rural hospital or community health center or mental health center, you're destabilizing and eroding that infrastructure. And so where you might have had two or three sites for your community health center or where your rural hospitals are, once you start eroding an infrastructure, it's going to be really hard to turn that around. So I think we're really incredibly worried about what this is going to do. Disparities already exist already now. The community health centers in Vermont, New Hampshire, and talking to my colleagues from the New England PCAs, primary care associations,
Yeah.
we're all looking at the community health centers that have really financially fragile. They have very little margin. And so there's going to be a lot of effect of both the Medicaid and with the marketplace. In November, by state initiated a healthcare policy think tank, and we brought in George Washington University as our research arm, and Capital Link, which is right out of the Mass League of Community Health Centers, as a organization that had a lot of data on community health centers to be able to do impact analysis for the community health centers, to tell them how many people do you think that you'll lose in the marketplace, how many people do you think that you'll lose in Medicaid, what does that translate into in terms of revenue and your ability to practice. We also had some government relations partners and some thought leaders. There's about 160 of us. We met almost weekly to try to understand and unpack what we were hearing, and also do some risk mitigation about what could we do to demonstrate nationally the value of Medicaid and what this change would mean. So I think the work requirement is going to be really difficult for states. We were able to get a provision in the bill that allowed states to be able to get a waiver from the secretary, HHS secretary, to be able to wait until December of 28 with the work requirements. So I suspect many of the states will be asking for that time, so they've got some kind of runway with their financials, to the state financials, to be able to take on such a big just a big practice, because every year, every Medicaid patient is looked at for determination of whether or not they're eligible for the benefits. And so that would mean all of your traditional Medicaid, along with the Medicaid expansion, all would get redetermined. And what's in the bill that I think is going to be really also hard for practices is that if you provide the service for a Medicaid patient and they were ineligible because they didn't get their paperwork in for demonstrating that they are on the work, that they had work, they actually, the federal government can claw back 3 months of that, the Medicaid resource that came to the state. So the state is going to be all states are going to be very cautious about making sure that everybody that is getting a Medicaid benefit is thoroughly gone through the process of being able to demonstrate that they have a work requirement. When we worked with Capital Link for New Hampshire and Vermont, and the New Hampshire health centers, there would be about a 30% loss in the marketplace, which is about 9,000 people, and that's about a $22 million revenue loss over 3 years. And in Vermont, it's 40%. So they would lose about 33,000 people with a revenue loss of closer to 70 or 80 million. So it is a real issue
Right.
for all of us, not just
Mhm.
the Medicaid patients, but for all of the practices as well.
Do you think down the road you'll see community health centers closing?
Yeah, it's a great question. We George Washington University did a study that looked at what did the community health centers look like 10 years ago before the ACA started, and the GW determined that of the 300,000 people that were the FTEs of currently of the community health centers, 300,000 would be down to about 150,000. They think that about 40% of the community health center sites would close, and that there would be just an enormous loss of revenue. So yeah, we anticipate that could happen here in New England, just because of just the loss of revenue and what sort of business practice they would need to do to sort of consolidate some of their sites potentially.
Yeah. I don't think people understand that whether it's 11 million or 17 million people who will be losing their Medicaid coverage, that when they get sick, someone's going to take care of them. Okay,
Right.
we may not have the health center, we may, but if they go to a hospital, that only increases the cost of their free care, uncompensated care,
Sure.
numbers. I mean, and I just don't know if people understand that someone's going to pay. You may be just shifting the money around, but the hospital,
Right.
are they going to be able to survive? I mean, we've already heard of some stories of hospital. I think there's one in Nebraska or rural Nebraska is thinking of closing because they're on the margin. And if they take
Mhm.
more of the Medicaid shift that they're no longer eligible to be on there, people who get sick and go to their hospital, they just can't afford to take care of them.
Yeah, no, I think, and I think we spoke earlier that the community health centers see everyone regardless of their ability to
Yeah,
pay.
they're
They
not
do
turned away.
not turn anyone away. So all of
Right.
these patients that were on Medicaid or on the marketplace, they're
Right.
still the community health center patients. They will still see them. So the amount of uncompensated care expected at community health centers is pretty significant. I think the
Mm-hmm.
same thing happens for rural hospitals as well. Georgetown did a study because I was thinking about sort of small business owners and what workers rely on Medicaid. And about a third of all Medicaid enrollees, including owners and employees and family members, are connected to small businesses. And as
Yeah.
you know from the New England Council, we run on small businesses. That's the
The
largest part
backbone.
of the economy
Mm-hmm.
for New England.
Yeah.
And so a large share of the small businesses are going to rely on this Medicaid in the marketplace for health insurance for themselves and for their employees because of the high cost of private health insurance. And we expect that private health insurance will go up as well. So there will be a lot of people that will have a loss. In New England, we have about 100 and a little over 100 community health centers, and they serve around 2 million people in New England with like over 9 million visits in one year. We serve about over 900,000 Medicaid and about 500,000 children. So if you think about just the stability of an organization um, to be able to weather this incredible difficult time, I think we're going to see a lot of changes, and I just sort of call that kind of cascading effect that
Mm.
that will happen in community health centers and also other practices as well.
Yeah. Looking ahead to the fall, we're now facing another fiscal cliff as
Yeah.
the current continuing resolution of the CR funding, the federal government's due to run out on September 30th. And it remains to be seen whether Congress will pass the appropriation package before that deadline or we
Mhm.
facing another extension. What are you most concerned about as that deadline approaches?
Yeah, thank you. So the community health center funding annually is about a $5.8 billion program. Part of it is authorized through the regular discretionary, about 30%. And then 70% of their money is a mandatory fund that started in the ACA. So all of that ends, that 5.8 billion ends at the end of September. And so we've been in a continuing resolution now for a year and a half at least. I anticipate that they are not going to be able to get through those 12 spending bills in Congress. I think it's just an impossibility. The budget reconciliation bill took all the air and the time. There's
Mhm.
probably only about 20 days left in Congress because they take the August recess. So I just don't think they're going to do the appropriation bills, which means we will either go into a shutdown, which is also a possibility, or we're in a continuing resolution. And that continuing resolution, my sense would be at least until December, or maybe short ones to get us to
Right.
December. So for the health centers, the way that they've worked in the continuing resolution is you can spend at last year's level. So the community health center program has continued without any increases. There hasn't been any increase to the base of the funding that goes to the community health centers for 10 years. So it's a very flat program, but a really important program for uncompensated care. So I suspect we'll be in this continuing resolution.
Mhm.
There was a lot of hard feelings in that budget reconciliation process between the Democrats and the Republicans. So they're going to have to figure out. I mean, normally Susan Collins and Patty Murray in the appropriators for the Senate, have go through the process of the regular appropriations in terms of getting their top line numbers, which they do not have, and then the process to be able to know what is going to be appropriated. They've only gone through 3 bills, and the easy bills. So labor HHS, which is what comes for the community health center funding, comes from the labor HHS spending bill. That's the most difficult one, and it just usually takes months to be able to get the top line number for that and the appropriation. So we are hoping for at least the federal discretionary and the mandatory funding to be flat. If not, then it creates just an incredible, complicated erosion again of the community health centers. So bigger investments for the community health centers to adjust to the rising costs that all providers have seen, all businesses have seen, the inflation, the tight labor market conditions. So I think we're very hopeful for at least the base funding, and potentially, because we're going to have this uncompensated care that we talked about earlier, that there might be an appetite for increasing the resources. But that's just not been how Congress has operated in the last several months. They're really in sort of a mode of cutting. So we're hoping to just at least stay the course.
You don't think they'll work through the month of August? Okay.
I do not.
Yeah, okay. It is a hot city, and the more ways than one in August.
Exactly. Right. Exactly.
Let's wrap up on a positive note.
Sure.
As we, you in particular, look back on your 30 years leading the Bi-State Primary Care Association. What are your accomplishments that you're most proud of? And then what is your vision for the organization's future?
Yeah, it's a great question. It's sort of took me by surprise to think about kind of a look back period of 30 years. But I think I'm most proud of the growth in patient access. So you've gone from 10,000 people to 330,000, and over that. So that's just a point in time in terms of the 330,000, but the number of people that have gained access to services in Vermont and New Hampshire over that time, I think I'm really proud of that. I'm also proud of how the health centers have built out this interdisciplinary model of comprehensive care. So not just the singular transactional visit in terms of Medicaid or medical visit, but also the mental and behavioral health and the dental and the vision and the pharmacy services. I think that's been really instrumental for community health centers. I've taught at George Washington University. I'm most proud, I think, of mentoring and teaching and coaching and providing networking, building meaningful relationships, business relationships for the community health centers and with the states and with the federal government. And I have to say, I'm really most proud of my team. We have a really skilled, compassionate colleagues here at Bi-State, and I don't do this work in a vacuum. I don't do it alone. I have an amazing team that helps me. And I think I see in the colleagues at Bi-State, I see in my colleagues nationally, as well as just kind of this enduring spirit and having the courage to forge on and to kind of find hope in times where it's really kind of tough. So I think if I had one hope, it would be lawmakers and thought leaders and businesses that really understood the dynamic power of primary care to be transformational in people's lives and to help sort of the healthcare of the community. And so there's no end in sight for the difficulties that the practices will see in terms of cost and competition and market pressure. But I think if people saw the community health centers, it is the largest network of primary care providers in our nation, and they made investments in primary care and primary care workforce. It's a tested solution to reduce the negative health outcomes and to make communities better. I think that would be my hope, that people would see the health centers as this incredibly dynamic, powerful primary care practice.
Well said. Well, again, Tess, thank you for taking the time to join me today and for the incredible work that you and your colleagues at Bi-State Primary Care are doing each and every day with all of the obstacles and challenges that we all face. But you are there and your dedicated team to provide New Englanders with access to health care. So we thank you. And of course, congratulations again on your 30th anniversary with the organization. And I would agree, it's an incredible accomplishment. So to those of you who are joining in, I hope you enjoy the conversation as much as I did, and I hope that you learned as much as I did. Be sure to tune in next month when our guest will be another incredible Granite State leader, Dr. Elizabeth Chilton, the president of the University of New Hampshire.